It's now my pleasure to welcome Dr. Matu Santoshem to present the 2016 Jimmy and Rosalynn Carter Humanitarian Award.
The Jimmy and Rosalynn Carter Humanitarian Award is named for President and Mrs. Carter. This award was established in 1997 by the NFID Board of Directors to honor those individuals whose outstanding humanitarian efforts and achievements have contributed significantly to improving global public health. It is in recognition of their efforts in this area that they were presented with the first award in 1997. Selection criteria for the award include legislative or administrative contributions, humanitarian service, and public education activities. Ladies and gentlemen, please welcome the 2016 recipient of the NFID Jimmy and Rosalynn Carter Humanitarian Award, Dr. Robert E. Black, for his work as global public health leader who's dedicated his career to saving lives of millions of children around the world, and for his tireless efforts to train other public health leaders. Bob Black.
No, this is a real award. It's something that you can put on your bed.
I'll let you. Thank you. Thank you, Matu, and thank you, Walt. I've worked with Matu for more than 30 years, and I appreciate his introduction and his nomination of me for this award. And I've known Walt for even longer, back from EIS days at CDC. So it's nice to see both of them here with me for this award. I'm, of course, honored to receive the Jimmy and Rosalynn Carter Award, the Humanitarian Award, and I thank the NFID for this. In the same week that I was informed about this award, I was very sad to learn that President Carter had melanoma, a cancer that had spread to his liver and his brain. And it's actually remarkable that through the advances of medical science and through the new approaches to immunotherapy that he is healthy today and without signs of cancer at the moment. And when he made the announcement of having the cancer, he said that he had had a full life, and he was quite accepting of his fate. And indeed, he had a full life, and he still continues to make contributions today, which I think we can be thankful for. To me, President Carter is the epitome of a humanitarian, working to improve human welfare, peace, social reform. If I were asked to introduce myself and say, well, who am I? I might have said I'm a physician. I might have said an epidemiologist. I might have said a child health researcher. Might have said a public health professional. Humanitarian would not have come to mind. I would not have called myself humanitarian. I'm certainly honored that others give me this accolade and think that I have made humanitarian contributions. Certainly in a much more modest way than other recipients of this award or President and Mrs. Carter. I have worked on the interventions and means to reduce child mortality, so child survival, if you will, has been my focus throughout my career in various ways. In 1977 as a young physician out of training in infectious disease and the EIS program at CDC. I convinced my wife, ever forgiving, that the next step was to go to Bangladesh. And that certainly was logical because first, diarrheal diseases were the leading cause of death of children in the world at the time. And Bangladesh was the mecca of diarrhea, or at least diarrhea research. And so it really was a logical place to go. And so I did begin work on field research on diarrhea pathogens, which was really more consistent with my training in infectious disease and interest in epidemiology. But I very soon learned that you cannot study infectious disease or deal with the infectious disease problems, and certainly can't solve them in those settings without dealing with the accompanying malnutrition. And so the malnutrition that made children more susceptible to infectious disease became, if you will, a co-interest, and looking at the interaction between infections and nutritional conditions really has carried through to today. And this research continued when I moved back to the United States, worked with Mike Levine at University of Maryland, continued when I moved to Peru to pursue similar interests, and certainly subsequently when I've been at Johns Hopkins. In Peru actually is where we began thinking about, well, what were the mechanisms that really were underlying this susceptibility, this nutritional susceptibility to infectious disease, and began some studies began investigating zinc deficiency. Zinc deficiency as a problem for plants and subsequently for animals had been known since the 1930s. But the demonstration of human zinc deficiency and its consequences was really demonstrated only in the early 1960s. And at the time that I began this work, it was thought, well, there's a rare condition of severe zinc deficiency, either very severe dietary deprivation or equidermatitis enteropathica, but these are rare conditions, and only the rare conditions would have serious consequences of poor growth of children or adolescents, increased rates of infectious disease, or in fact, in very severe cases, death. However, through some animal models and through some observations, it appeared that perhaps even more mild or more limited levels of zinc deficiency would have some consequences as well, immunocompromise and increased rates of infection. So the correlations that we found between zinc deficiency and diarrhea were interesting, but it seemed that one could not really know if these were causal relationships without doing trials. And so that led for me to about 20 years of randomized controlled trials of zinc supplements in Latin America, Asia, and in Africa that I think demonstrated the causal link between zinc deficiency and immunocompromise, increased rates of infectious disease, severity of diarrhea, actually pneumonia as well, and increased rates of mortality in zinc deficient children. So this is a long story, and it is still playing out in terms of the interventions, some of which are now universally recommended, for example, zinc in treatment of diarrhea, and preventive zinc supplementation where it's indicated. So I guess another aspect of my life at this point is, if you ask me when I started my career, would I call myself an advocate? I would have said, what is that? And why would I want to be an advocate? I'm a scientist. But in fact, I think I've also, in addition to the science, have become an advocate for child survival. This has included developing and presenting the evidence for what interventions work, what are cost-effective and affordable and can be implemented in low-income settings to reduce child mortality. And actually, the world has made tremendous progress. Since 1990, the rates of child mortality have been cut in half. So in a relatively short period. And so we actually know that there are very powerful interventions, particularly against the infectious diseases, so treatment of diarrhea, pneumonia, malaria, the introduction of new very efficacious vaccines, and the reduction of nutritional deficiencies, I think have all contributed very much to this mortality decline. None of these interventions are as dramatic as immunotherapy for cancer, but I think collectively they're very powerful interventions that have very profound benefits for reducing child mortality, and they are low cost. They ought to be able to be delivered in all of the low and middle income countries in the world, and yet they're not. They're not yet sufficiently developed and implemented in settings where poor children are still dying. There's still 6 million deaths of children every year, and I think this is unacceptable. These are preventable deaths. However, the progress in recent years does give me hope, gives me optimism that, in fact, these deaths can be prevented, and there are now targets that in fact, could be achieved, that these deaths could be prevented in another generation. So I would end with just a quote from President Carter. We can choose to alleviate suffering. We can choose to work together for peace. We can make these changes, and we must. So again, I thank NFID for this award and giving me this opportunity. Thank you very much.